All right, welcome to the Lake Norman Chamber of Commerce Focus Friday. And we have Novant Health, and it's going to be a focus on healthcare. But before we start the program, I'm going to recognize the 2026 board chair, Leah Trowbridge, who's prepared her remarks this morning about last night's event.
Good morning, everybody. Glad you guys are here. If you weren't at the gala last night, I think it was fabulous. So much good networking, so much excitement and support for what's been going on. Well, for the last 30 years under Bill's fabulous leadership, what's been going on last year, and particularly with the AI Summit, and then what's going to be coming up with the next AI Summit, our pickleball tournament in May, and programs like this, and all of the good activities that we do. So, again, I'm Leah Trowbridge. If you don't know me, please feel free to reach out directly with any questions, concerns, or how to be more involved.
All right, and Michael, we're making you a co-host now so you can share your slides. And now I'm going to turn it over to the 2026 Public Policy Chair, Pat Jackson.
Oh, good morning, everybody. Good morning. First off, we have, pass that down, Professor Osborne. We have a raffle today for four Charlotte Knights tickets. So if you don't have a card, put a little piece of paper in there, or put your business card in there, and your phone number. Any game, we'll figure out a schedule. So it's great. Thanks, Bill. And yes, the gala was wonderful last night. So big turnout. What a great community. So, and here we have the team from Novant, Mr. Mike. Good to see you last night as well. You're going to give us an update on what's going on in healthcare, right? This is always one of our more informative programs, and I think you were saying the kids, the junior leadership team, they really love listening.
They were there a couple of weeks ago, and if you our junior leadership Lake Norman program that looks at all the various sectors of our community. Always ask them, what session did you enjoy the most? And it always comes back healthcare. Part of it is normally the helicopters. But they couldn't have the helicopter last week because of it was messy, but they had the ambulance, and that was pretty good.
Yeah, it's pretty good. So again, before we let Mike introduce his team, thank you to the staff at the Chamber. What an event. I know that's a lot of work, and the Peninsula Club does a great job as well. It's wonderful. So Mike, would you maybe start by introducing your team?
Yes. So thanks for having us today. You know, we sponsor Focus Friday every month, and it's always the topics are always fantastic. I hope that we can live up to the expectations for what usually happens on Focus Friday. My team here, we've got Dr. Bikki Gautam. He is our Chief Clinical Officer. He helps me run the hospital, all things physician related, all things clinical related, all things quality related. That's him. Dr. Cain. He is my physician partner for the North Market for all things strategy. So we work together to figure out where we're going to build new clinics and put in new surgery centers and that kind of thing. And then Moody is our chief nursing officer, and she essentially runs the hospital.
Well said.
It's funny. The doctors will say the same thing. You keep the nurses happy, your hospital runs very smoothly. If you don't, all kinds of bad things happen. So, these are the folks that we all work very well together to make sure that the hospital runs well, and then all things outside of the hospital, ambulatory care and elsewhere outside of the community works well. So that's where we are. And so we put together a presentation that we're struggling to get up. My IT guy is working on it. I'm trying. But we're going to go forward, and we'll work off of our slides here. And if we can pop them up at some point, we will. As we talk, very open. If you have questions, don't hesitate to jump in. We're going to try to save some time, 15, 20, maybe 30 minutes at the end for questions. So be thinking of questions that you might have. But we'll give kind of an overview of some things and then kind of move on from there. So first thing, just healthcare in general, you know, and we want to address this to the Lake Norman community and to business owners, because that's really what the chamber is made of. Things like time to access, things like insurance complexities, things like higher premiums, and then what is it like for recruiting nurses and recruiting doctors, and we'll talk about that a little bit. What's changing up here, I don't think I have to tell you guys that population growth is crazy, and so how do we take care of all the people that are moving into this community? Care shifting, 100 years ago, 50 years ago, the hospital was all you really thought about when you thought about healthcare, and everything else was kind of an afterthought. And now the way we put things together from a healthcare perspective is, yeah, we look at the hospitals, but we look at the continuum. So how do we take care of you when you're healthy and keep you out of the hospital? And then once you have to go to the hospital, how do we make sure you don't have to come back? So all of this is a big continuum, and we look at things that way versus just critical care and acute care. It's much more about the continuum. Costs are rising in healthcare. I think you have to be living under a rock if you didn't realize that. That's always happening. We'll talk a little bit about that. And then some of the things that we're doing to grow access, to try to minimize costs where we can, recruit and retain good physicians, good nurses, good clinicians, and then looking at things that are probably really important to you, keeping your employees, yourselves well. How do we make sure that we get people into the mammograms and the colonoscopies and seeing your physician once a year, all the screening things that you need to do to catch things early so that you don't end up in the hospital. Something that we look at Novant, and that kind of makes me proud of Novant, is the way we evaluate our success, I guess. And we have 5 pillars that we look at. One is our team member well-being. If we don't take care of our team, we can't take care of people. So that's very important. Safety and quality, that's crucial for us. You come to the hospital, you expect high quality, you expect to be taken care of, you expect to get the right medicine, the right surgery, the right everything. And we need to make sure that that's right all the time. We don't want readmissions, we don't want infections, so we try to minimize that as much as we can. Patient experience, we want to take care of you from a clinical perspective, but we also want to take good care of you. We want you to have a good experience. Nobody wants to come to the hospital, right? Unless even when you're having a baby, that's not always that's a painful experience. So we want to make sure that we minimize any suffering that we can and make sure that your experience is as positive as possible. And then operational excellence, there are, well done. As far as operational excellence, we want to make sure that we're as effective as we can from a financial standpoint, from a lean standpoint. We want to do things effectively and efficiently, and then we want to grow. What we have learned in healthcare over the last 5 to 10 years is if we don't grow, we shrink. And so finding ways to make sure that we're growing in the Lake Norman community is hugely important for us. And the really good thing about this is that as a system, all of these things are equally weighted. So if the hospital's making millions and millions of dollars, but our quality's poor, I'm failing. If our patients are really happy, but our employees are miserable, I'm failing. So we need to make sure that all of these things are equally balanced and all the time. So what is Novant and where is Novant? We're a not-for-profit health system, and what that essentially means is that all of our profits go back into the company in the way of either employees or capital, building new things, paying for CT scanners, all that stuff. It all kind of goes back into the company. We have 3,600 physicians and APPs, and APP is a advanced practice provider. So that's a CRNA, a PA, a nurse practitioner. We have 22 ambulatory surgery centers and 85 urgent cares throughout North and South Carolina. 20 acute care facilities, so that's hospitals with 3,600 beds. 35 diagnostic imaging centers and well over 40,000 team members. So we're a pretty large company in and around North and South Carolina. Locally, we have 7 hospitals in the greater Charlotte area, and this is what you can kind of see from here. We have, and Charlotte has 2.27 million people in it. The population growth of people aged 65 is 15%. I'll talk a little bit more about what that growth is in Lake Norman. It's even higher. 72,000 discharges. To put that in perspective, at Huntersville, we had about 9,000 discharges last year. Total ED visits, 245,000. At Huntersville, we did 42,000 last year. Outpatient encounters, 639,000. I'm not sure how many outpatient encounters we did, but it was probably 20% of that. And then 77,000 surgeries at Huntersville. We did about 6,500 last year. And almost 12,000 births at Huntersville. We did about 2,100 births last year. So that's kind of the perspective for where we are against the greater Charlotte market. Also, interestingly, there's 2.27 million people in the greater Charlotte market. North of 85, there are 600,000 people. So this is a metropolis in and of itself.
Mike, the 15%, is that the Charlotte region?
That's the
65, or is that your patients?
That's of that 2.27 million people in the greater Charlotte area, 15% of them are over 65. And spoiler alert, I'm going to get to it, but in the north of 85 market, the population is even higher up here, and the growth is even higher up here. So some trends in healthcare. This is my favorite slide. I show this all the time because it makes everybody mad just off the bat. So inflationary growth. So if you look at the blue line at the bottom, that's inflationary growth from 2000 until 2024, I think. The green line on top of that is the inflationary growth of healthcare. So you can see there's a disparity. So that's what people feel, that's what people see, is that the cost of healthcare is growing at a faster rate than the growth of just regular inflation. And inflation is already growing at a pretty significant clip. And why? There are a million reasons for this. Interestingly, a lot of it is counterintuitive. I think, and I say it's a little shocker for this too, competition is a chunk of this. And you would think that competition would bring costs down, and it's actually the reverse. If you have a Lowe's and a Home Depot or a Target and a Walmart, they're going to compete to get you in by bringing their prices down. Who has ever needed surgery and looked for the cheapest surgeon? Right? You just don't do it. And so that's an example, but everything is like that with healthcare. If your mother, father, wife, sister, cousin needs something in the hospital, you want the best, and most people will pay for the best. And I think the medical device companies, the hospitals, the pharmacy, the drug companies, they know this, and so they're incentivized to invest in better, bigger, faster, healthcare. And when they do that, the cost goes up and up and up. It's actually getting a little bit better over the last few years. The disparity is getting a little bit better over the last few years because there's a lot more pressure from you as business owners and insurance companies to kind of bring costs down where you can. But even so, an example I always use is if I have a 5-year-old MRI that costs $2 million and it's probably got a 10 or 15-year life, and my competitor down the street buys a brand new MRI for $3 million that does maybe mine can find a tumor that's this big, but that one can find a tumor that's this big. Well, if they bought that thing for $3 million and it's brand new, and now people are going to that facility, and part of it is a competition thing. They're going to that facility. I want to compete, but also I want to give the highest quality care possible. So do I trade out my MRI that's got 5 or 10 good years in it for a $3 million MRI, or do I keep that doesn't compete as well and maybe doesn't give the same high level of care? And so that's kind of the constant battle that we face for getting better or being better. And when we do that, the cost gets higher. So that's the struggle, and that's a big part of that. There's certainly other factors that are involved in that, but that's one of the things that that really kind of pushes the cost higher. So some of the other reasons why healthcare is harder now is aging. You've heard of the silver tsunami. We're in the middle of the silver tsunami. About 10,000 people every day turn 65, and as you get older, you need more and more and more healthcare. So that's a big factor. A big push on us is how do we take care of this huge, bigger and bigger and bigger number of people who need higher and higher levels of care. And then I know Allie's going to talk a lot about workforce and nursing and that kind of thing, but there's a whole other element of that as humans get older, nurses get older, and so we have nurses who are aging out, retiring, and that makes that harder. Affordability is tough. 20 years ago, everybody's insurance plan was paid for everything. You didn't have to worry about whatever. You went to any doctor you wanted. Your deductibles were low, your premiums were low, and so you just did what you did. But that over time, as you saw, as the healthcare costs got higher, the burden on the businesses got bigger and bigger and bigger. And so they started to push that onto their employees. And so now you hear a lot more about, oh, my premiums are so high, or my deductible is so big, or, you know, the co-pays are so big. And so now people are feeling that. And so and that's why I said there's a little bit of a shift going on now in that disparity between inflation and where healthcare is, because people are shopping a little bit more, and they're demanding a little bit better pricing, but still they want the best. And so it's an interesting dichotomy of, I want the best, I don't care what it costs. Why did that cost so much, kind of thing? And that's something we struggle with all the time. This is a little bit about the age, some statistics that I like to show. Lake Norman grew by 7.9% over the last 5 years through 2024. The 65 and over population grew by 22.5% during that same time, and are projected to grow at about the same level. So you figure that's 3 times the 65 and over population are coming to Lake Norman at 3 times the rate of population growth, and so that in and of itself puts a huge strain on healthcare, because we need more beds, we need more physicians, we need more nurses, and that's a big part of what we do. I thought the on the right was interesting too. In 2024, about 1 in 5 North Carolinians were 65 and over. That's 20% of the general population of North Carolina. In North Carolina, residents 65 and over projected in 2040 is 2.7 million. There are 10 million people give or take in North Carolina, so that will go from 20% of 65 and over to 27% by 2040. So that's very interesting. In 2031, older adults are projected to outnumber children in North Carolina. So
that has a lot to do with the birth replacement rate, though, as well.
Right. Yep. For sure. Yep.
Billy, you better have more kids.
I have a dog.
And then and I'm gonna stop talking and hand it over to Brian. But just some of the questions, why are costs rising? We talked a little bit about that. Can employees get in quickly when they need care? And Brian's going to talk a lot about the difference between primary care versus urgent care versus ED, and when to go and what that looks like. And keeping healthcare close to home is another priority for us. People don't want to know. We live in Lake Norman. Nobody wants to go to Charlotte for anything, except for maybe the theater. I don't know. But nobody, and we have Cain Center, so we don't even need to go down there for that now. But that's a big part of why we're trying to bring as many services here as possible. And then technology, and Brian will talk about technology and all one more cost thing while I'm talking about technology before I give it to Brian, and Allie's already giving me dirty looks. We were at the juniors came to the hospital a couple weeks ago, and one of the kids said, do you think with the advances in technology that's going to bring costs down? And I thought about it for a minute, and then I said, no, it's not. Because what I've seen over the last 20 years is every new piece of technology costs more and more and more, and you've got to get your software upgrades. And then there's a new product that's twice as good as the one you're using now, and you have to spend more and more and more. So I think it will create efficiencies, which may save us some money. But as far as cost in general, I think it's just like pharmaceuticals or orthopedic implants or whatever. They just get more and more expensive as the technology gets better. So bad news. And then keeping your workforce healthy. Again, we reiterate, make sure you get your screenings, see a doctor every year. It's a great way to catch things before it gets out of hand. All right, I'm going to hand it to Dr. Cain.
All right. So Mike did an amazing job of talking while I struggled through the technology piece, and so you see me not do that quite as well because it's not working for me right now as I do it. Trying to get the slides to flip here. There we go. One thing, just to comment on something Mike mentioned about that technology, and I guess I would point out is, in the first few years of a new technology, it's usually really expensive. At first, it's not till we have years of funding it, perfecting it, does the price come down. Healthcare is always driven to really stay at that leading edge. And so we're seeing some of that initial investment in that upfront technology. And that has benefited us. Just as an example, we take lessons from businesses, we use lean processes, improve our protocols, and we do that in, for instance, stroke care. Well, some of the things we do in stroke care, one of those technology pieces is we use AI. We're using AI to help us more quickly identify areas on a head CT where we can identify stroke. The AI technology kind of brings areas of, hey, this may be a concern to the radiologist. This looks like there's some difference in blood flow or this tissue may be damaged, and can call that out a little quicker. So it's identified a little faster. It speeds the time to which that patient can get to the intervention, whether that is, addressing the bleed that they may have, or the clot, and get them into the clot removal, or the clot buster medication. We're leveraging that, along with the new technology, not just AI, it's improved techniques. We have improved techniques of how do we go in and get that clot? How do we break it up? Can we deliver something via catheter to just that spot so we minimize bleeding risk? Because anytime you give something to break a clot, there's a chance that they're going to bleed. So you see that in just our advances in that constant push to really make sure we're delivering very high quality care with really good outcomes, and also in a very safe fashion. And if you don't hear me say safe multiple times, I'm probably not representing Novant very well, because that is a huge focus. We do the same thing with our cardiac care. We instituted STEMI call, or STEMI care, which is more advanced heart attack care several years ago, and continue to look for ways to make sure patients in the Lake Norman community can get that really high quality care close to home. You see us trying to expand our emergency department capabilities, expand our access not only in our emergency department on the Huntersville campus. Here talking a little bit just about making standalone emergency departments in the community and having one of those sites for more Charlotte. And fairly close to this area. There's always new medications. If you've gone to the doctor, they probably talk to you about medications. Many of your businesses have experienced the cost of new medications, particularly weight loss medications that have really transformed the treatment of obesity, and it has become a very, very popular thing across the landscape, and lots of people interested in figuring out how to get it. As most of you probably know, it is not cheap. Those medications still remain very, very expensive. Along with, I guess I would say, if those weight loss medicines are expensive, a lot of the chemotherapeutics and medications for cancer are even multiples of that number. We're seeing great improvement in the cancer space, but we're also seeing those costs also drive. We also have lots of infection prevention, patient safety programs. That is something that we take great pride in. Dr. Gautam will talk a little bit about that in a little bit, but I won't steal his part of his presentation, but that is a high focus. For us, let's see if I can get the slide to advance. All right, there we go. Really wish this would. Sorry, there we go. We're focusing on several things that you'll see us over the next months and years. We'll talk about primary care. We think it's very important for our community to have a primary care doc, have a relationship where they can establish trust. Prevention really happens at that primary care location. with that provider, that physician, that APP. If, the sayings an ounce of prevention is worth a pound of cure. That really makes a big difference. Having that relationship where you can talk about what are you doing to stay healthy? What are we screening for? You're getting your cancer screens, or screening your cholesterol, we're looking at your blood pressure. What sort of healthy habits do you have? How are you eating? How are you exercising? That is really important, and we're trying to expand those access points. And then our same day access points, you've seen some of our urgent cares are continuing to expand that, even expanding some of the just ease of which walking into our offices and getting care when you need it, from across the line, whether it be primary care, our orthopedics, if you have injury walking into our ortho clinics, if you have a sports injury or, fell and injured your wrist, those sort of things, and trying to get urgent evaluation by an orthopedic, and not always having to go to the emergency department where you're gonna be put in line with things that may be less serious, maybe more serious, and then potentially have a wait. Growing our capacity for higher acuity care, and making sure that you don't always have to go into the heart of Charlotte to get your spine surgery, or the advanced cardiac care. All that is really important, and then the workforce challenges, we're trying to recruit and make sure we have our specialists that you need across the spectrum, whether that be neurology or rheumatology, endocrinology, all of those specialties right here, and then trying to make it affordable. Not everything has to be done in the hospital. As many of you likely know, going to the hospital is not the cheapest thing in the world. And so if we can deliver it in a cheaper side of care, that's an important thing, and we're working to expand those access points as well. And so some of the examples of things that we're working on right now, we are working on a freestanding emergency department in closer up 77. It's not the easiest when there's rush hour traffic to get down to exit 23 for me. Hopping in the express lane isn't always easy or the cheapest thing. Especially when you have an emergency, you want to be able to get care. So we're going to try to move that up further outside of this to make it more accessible to our Lake Norman community. I mentioned primary care access points, just an example there. We're going to expand a clinic and open a new clinic in Davidson, likely in Q3 this year. Expanding our hospital services with our interventional radiology, as well as advanced CT support to do both vascular and cardiac cases. And there's a very interesting technology called a CT angiogram, which is kind of replacing the stress test in a lot of ways, and bringing Africanization. So in investing in that technology too, and then expanding our capacity at Huntersville with inpatient beds as well as the less acute observation beds. All right, that is not. All right. Yeah. Sorry. When you need your doctor, this just getting to them is really important. As I mentioned, I think it's really important as a primary care doctor. I think it's important to have a primary care doctor, have that relationship, somebody you can reach out to the office, whether it be during typical business hours, after hours. All our offices have a nurse triage line. You can call them and say, hey, this is what's happening. Do I wait till the next day? Do I need to be seen right now? Do I need to go to the emergency department? I think having that primary care place is vital, but also we also could expand virtual care. I don't know if I would say this is a great thing, but it is something that has been a positive to expand access, is all the virtual care. The pandemic caused a significant shift for all of us, and this Zoom that we're all on has been part of it. Getting used to seeing people in boxes, but getting your healthcare that way too is an option, and that is something that we have. We have a 24/7 access to that. And then, whether it's, hey, yeah, you did fall, you hurt your arm, you have the flu, you need that, it's Saturday evening and you're feeling terrible. What do you, urgent care is a great place for that. And then when it escalates, if you have, hey, I think I might be having a heart attack or stroke or emergency department. And if you're unsure, we have places where you can reach out and figure that out too, like, hey, what's the best place for me to go? And then trying to make those transitions easier for patient, whether that's, being in the hospital, or even recovering and following up or at home. Our hospital stays, are trying to get shorter and shorter. As safe as we try to make your hospital stay, the hospital is not always the safest place. Lots of things do happen. And so trying to get people to recover at home, there's infection risk at the hospital. So we do try to get you out of that infection risk. And then a lot of the recovery goes, it happens at home. For instance, our hip and knee replacements used to be a multiple day hospital stay. There's sometimes no hospital stay. People go home same day and recover. And actually do better. And less infection. I'd rather sleep in my own bed than a hospital bed, if I'm honest. So, all right. Let's see if we can get it to advance. Okay, so one of the things, why wait times happen, lots of things happen, whether that's at in the emergency department because it's really busy, or getting into the specialists. This kind of talks about one of the workforce shortages that we're facing. This is the physician supply and demand that is projected over the next about 10 years. You can see the demand on a national basis and the supply, and then you can see in North Carolina where we are. There are not enough physicians to meet the needs. And that is, some of it is training, some of it is residency, some of it is just, we need more people going into it. Part of it is the aging population, or population growth is not symmetric. And so we have differences in people are hiring or not being at where they can go into the medicine. Now, that is physicians. There are advanced practitioners that are going to help fill that gap, but that is why you see more and more advanced practitioners in offices, in the hospital, filling in that setting. And we're leaning on them to help meet this demand and making sure they're well trained and doing things in a very collaborative fashion with our physicians. But it is something that we're taking a very strategic approach. We know, we as Novant, we have a lot of expertise, but there are other physicians who are in the community who are independent. We try to partner with them to make sure we're trying to meet demands of the community as well as strengthen those pipelines of collaboration. That's also why you see us having residency. We have a family medicine residency here in Cornelius. We're expanding our physician residencies at our Presbyterian campus to try and build a pipeline to help meet this demand, to try and both train really good physicians as well as retain them.
Just a quick question. Charlotte doesn't, I don't think, but why doesn't it have a medical school?
Great question. It's a complex.
We just got a law school.
Correct. Yeah. So we do have collaboration. We do serve, Novant does have a partnership with the UNC School of Medicine, and we do host medical students and train them in our Charlotte hospital. We don't have a lot of those right now. We may be expanding that at some point in the future. It requires a big investment in both teaching capacity, as well as there's the first few years of medical school is a lot of lecture, very intensive instruction, and a lot of those are done by research basic scientists. It's not always bedside clinicians doing it. The last 2 years of medical school do tend to be more clinical rotations, bedside, and that's where you'll see us partnering with med schools, and even see School of Medicine is one where we're doing that some. But I think it is an opportunity for Charlotte because it is a huge city. To not have a sizable med school is an opportunity. I do think Atrium is exploring some of that in their partnership with Wake, but we have done that with UNC.
So Charlotte was actually one of the fewer big metros that did not have a medical school. So because of that need, Atrium in collaboration with Wake Forest, actually started a medical school this year.
Oh, they did?
So they did. They took the first batch of students, the first years. Yeah. So there's an innovation district in Charlotte called the Pearl. That's where their medical school is. Yeah, it's great.
So we're having some technical difficulties again, trying to get the slide to advance.
So we'll hand it over to Dr. Gautam and talk about safety and quality.
Safety and quality. So thank you, Brian. Mike started the presentation talking about the 5 strategic pillars for Novant Health, and we always talk about operations and all of that, but when you think about a hospital or a healthcare system, you're probably thinking, if I go there, is it the best? Is it safe? Am I gonna die? Am I gonna have an infection? Right? Like when I go to a restaurant, the first thing I look for is like, what's their safety there? Like, am I gonna go home tonight and have a bad outcome? So, when you go to any hospital's presentation, they're probably gonna say we're the best, we're the safest, but how do we have like an external benchmarking to validate the work that we're doing? So Novant partners with Leapfrog. It's one of the national organizations that looks at all the things that happens inside a hospital and gives you a grade. So one of the things that we're proud of is Huntersville has consistently been a Leapfrog A, actually in 9 cycles in a row. So it's public facing, when you see a lot of that coming out in the Charlotte Observer, but it means that when you go to a Leapfrog A hospital, there's less hospital-acquired infections. It's safe. You have a better patient experience. One of the other things we also look at is what we call CMS star rating, which is like a Center for Medicare Service, and they look at the overall picture, like mortality rates, like what is the rate of sepsis if you have a surgery inside a hospital. How's the patient experience? Like, do the nurses listen to you? Do the physicians listen to you? So there's only 30 to 35% of all the hospitals in the nation that are CMS 4 or 5 star, and Huntersville is a 4 CMS star rated hospital too. So we put a lot of effort into making sure that we have all the things that you as a patient or family member have the confidence that when you go to any of the Novant hospitals or Huntersville, that you're going to get the best care out there. So not just Huntersville, but across the Charlotte region, we're very proud of all of our hospitals. 3 of our hospitals are a CMS 5 star. We also partner with this external benchmarking company called Rizian that cohorts us against hundreds of hospitals across the nation. And we are performing really well in that work too. So we're in the top quartile, and some of our hospitals are in the top decile. We put some selected awards and recognitions that the Huntersville Hospital has received over the past. As you can see, we do have a residency program, family medicine residency program, that is based out of Cornelius and Huntersville. And we were recognized as top teaching hospital by Leapfrog in the last several years. We are a primary stroke certified center. We are a Vision 5 star hospital. We are also recognized by, what we call the American College of Cardiology when it comes to like heart failure treatment, stroke treatment, and all of that stuff. So we're doing a lot of great work there. What does that all mean? I just wanted to kind of show a brief snapshot of like when you see the awards and recognition, how does that translate to actual patient care, right? So we recently had a survey from the American College of Cardiology where they go to a hospital, if you're a STEMI center, and look at all of your times, all of your metrics. And I want you to go to the third line and look at that STEMI D2R median time, where the 50th percentile of a hospital that can treat heart attacks. So D2R needs, if you show up to the emergency room right now, how fast can you take that patient, do all the testing, take them to the cath lab, do the stent, and open up your vessel. So if you see our go-to reperfusion median time was 42 minutes, when the national like 50th percentile is 62 minutes. The other you can see is STEMI E to B time. It's the same thing, but that's if you were not at the emergency, but like you were at home and you called 911 and the EMS showed up and now they have to like talk to Huntersville ER, put you in a van, take you to Huntersville. Still that we can take you to the cath lab and do a stent and within 68 minutes when the national like 50th percentile benchmark is 84 minutes. So it just goes to show you that we have a hospital that is capable of delivering results that is way better than a lot of the hospitals compared in the nation. So just, yeah.
Excellent.
What this means, I just wanna, so STEMI is essentially a heart attack. And when we're talking about, like, so the goal was less than 90 minutes, that ET means, meaning the time it gets activated to the time we expand the balloon, get blood flow. So when you're having a heart attack, that means blood flow is not getting to your heart and could create permanent damage, which impacts the functionality and could significantly limit your ability to do daily activities or things that you love, right? So the faster we get that open, get blood to that heart tissue, the better your outcomes are, the less long-lasting impact. So standard is 90 minutes. And so to Dr. Gautam's point, in this community where we have traditionally been considered a small community hospital, we are now able to do things that only tertiary large facilities used to be able to do. And we keep you in this community, and we're doing it better than even some of the larger, more high-tech facilities that you see in this area.
Does activated mean from the time they hit your door or they hit the ambulance?
It can be either or. So it depends on, so we do have a process where we partner with our EMS partners and they can actually send us like your rhythm strip. So they can be sitting in your house or at Chili's or wherever you guys are. They run that, they can beam it to us, and we're going IT terminology, but we can see that and we can activate it. So we could literally have our CAF team come in who already have to be there within 30 minutes. But we can get them there even before you're hitting the door. If you walk in and we note that, then we also, that would be our activation time.
After you all finish, one question that I always have is what we struggle up here with the emergency system. It particularly in Davidson, they can't find Davidson. So the rule now is.
You mean the medic system?
The medic system.
Yeah.
So when you call, we had a situation on our street where somebody was having a post-heart attack or something, and the EMS operator kept asking, well, is this life threatening? I'm like, well, yeah, they're almost dead. Finally, that's what I have to say. And I'm talking to our police chief on the other line. He said, just tell them they're dying. Because we just can't get, we've struggled for years to have the ambulance service up here and in place and have opportunities. In Davidson, we tried to build a port for them at one of our new fire stations, and that fell apart. I know that has nothing to do with y'all, but it's the front end of your emergency system. So just would love some focus on the emergency response opportunity.
I will say we do a lot in partnership with this, like some of our medic partners even sit on our like quality review board. So that's good feedback. And we just had.
It's terrible. I'm just gonna tell you, getting to Davidson is terrible.
So with that partnership, I'll take it back to my emergency services manager and she can start having some conversations. Not again, it's not much, but it's good to know that, right? Because we do tend to collaborate and partner with outside agencies, trying to find where are our pockets of opportunity so we can continue to improve this. So that's good feedback.
I would warrant that every new fire station around would offer a port to an ambulance service.
Beth, just so you know, this was identified last year. The towns have gotten together as well as Charlotte and kind of spoken up about some of the medic services. It's not just your imagination or just your experience. They're large, compared to most metro areas, far fewer ambulances and the EMSs out there to service us. And historically, they've, with the tools they've been using, not specifically y'all, but, it leaves a lot of the ambulances down in the Charlotte area. And then they have to come up here, which has been causing the problem. there's a lot that contributes to that. So we've all kind of called it out and gotten together, the 3 towns especially, and all the other municipalities have shared an interest in this as well. And there's currently a significant study going on, a third-party study, not, being done specifically by the hospital or by EMS to look at the entire network, because it's definitely not meeting the needs. And it's all the way from the IT portion of it of, hey, how do we see where the ambulances are? Where do we drop the ambulances to, shortages in staffing for EMS. But as a whole, you're exactly right. And they are taking a very hard look at it right now. We're expecting some of our first results from the studies being performed shortly.
That's great. Let's let Dr. Gautam finish his presentation and we'll turn it over to the nurse Sally.
All right, I think Brian kind of alluded to some of this, but virtual care is one of the solutions that is going to be a part of our daily lives. There's a huge physician shortage. You want care when you need it, right? Big companies like Amazon are literally offering video visits now over the phone. So we are investing in a lot of like technology and access so that it's up to the patient. If they want to go see their doctor, so be it. We want to deliver that too, but we also want to invest in better early detection technology and AI. Of course, AI is the talk of everybody's mouth right now. Just a statistic that digital health is going to continue to grow, and it's going to be a huge part. They're predicting that by in the next 10 years, 23% of all visits are going to be virtual. We talked a little bit about AI. AI is not here to replace physicians. I hear a lot of that from radiologists and pathologists. Hey, is it going to replace doctors? Are they going to be smart enough? How I look at AI is more of a synergistic approach. We're using AI to make sure that in this demand supply mismatch, that they can work smarter and faster, and it actually enhances the work that they're doing, not replacing them. And AI is not just in physician practices and radiology, but AI is being used in supply chain. How do we optimize stuff? Nursing, a lot of that. So you'll continue to hear a lot about AI, I'm sure. But Novant is taking a very proactive approach in this one too.
Are you available next February, maybe around the 3rd week of February?
There you go. All right, I'll pass it off to Allie.
And I tend to, this might get sturdy looks, I tend to always get the last little bit and I've got to talk fast. So if I go too fast, just let me know. So tell as old as time, nursing shortage. It's not a surprise when I started nursing 24 years ago. It was there then and it's gotten only worse as predicted since. Just a few statistics that you guys can see up there. But essentially when you're looking at just acute care hospitals, there's an average of around 15% vacancy rate. ICs are even higher. When you pull it all the way down, so I'm not going to keep going through all that. For us at Huntersville, our acute care RN vacancy rate is better than what our national average is. So we sit at around 11%. We've done a lot of work to improve that, especially post-pandemic. But the other compounding thing to this is some of the other things our nurses are up against. And so it's really not as much of a shortage, especially in certain areas like this, as much of a retention. We're seeing a large shift of acute care bedside nurses leaving the bedside, whether it be retirement because of a lot of our aging population, or workload stress. They don't want to be in the midst of, we have a lot of workplace violence. I'll go into some of that here in a minute. But also because of all the great work we've done, we are seeing a shift of your less acute patients staying at home. And so what we have is the more acute complex. And so I don't know that nursing or healthcare as a whole has done a great job keeping up with that shift of acuity. And so while we keep our nurse to patient ratios relatively the same as what they've always been, our acuity of those patients has increased significantly. And so that increases that mental workload and burden on the nurse. You wanna... So when you think about our nurse stress, it's not just about the overall job, but you think through the workload. So 60% of nurses report working overtime regularly. We already traditionally work a 12-hour shift, 3 days a week. Some people work a little different. But when you think through, we're essentially pushing all 40 hours into 3 days. That's a long day for people. Again, talking about the acuity, that creates a lot of feeling of anxiety and being overwhelmed. Nurses don't go into this job to just kind of skate through and get the bare minimum. They care about their patients. They want to do the best. And sometimes at a even 5-to-1 ratio, which is very good when you look at the standard for your med surge. So the lowest acuity departments within the hospital, that's a good ratio, but when you have the acuity, that can still be a lot. In addition to that, just the documentation alone. So in a 12-hour shift, we have AI programs that do this. I love AI. I'm a little bit of a data geek. An average nurse spends around 2 to 2.5 hours just charting. And some of that charting, it's required by DHSR, by CMS, by Joint Commission. And so it's not something we can just be like, oh, just don't do it today. Like they've got to get that done. But also in our society, we've moved to a very litigious culture, and that is starting to hit nurses at the personal level. So I know over the last 3-4 years, you guys have seen a lot of things in the news where people are going after nurses personally and specifically, which historically hasn't occurred. And so that also adds to that mental anxiety and burden. And then you need to make sure we're documenting to kind of cover our findings. To make sure we're telling the story when somebody's looking at this 6 months, 2 years, 5 years down the road, I can go back to my charting and know exactly what I did and say, no, I met the standard, I did what I should have. Then you look at workplace violence. I know I talked about this some last year when we were here. I've spoken about this. It's something I'm very passionate about. 38% of nurses report experiencing workplace violence. I'm going to tell you it's probably double that. It's very underreported. There is a perception that we, as nursing, have compounded ourselves where it's just a job. This is just what I'm expected to deal with. And so we've done a lot of work trying to move nurses out of that mentality. It is not my expectation as their chief nursing officer that they put up with verbal abuse, physical abuse, mental abuse. And so we have to do continuous education, and I'm getting ahead of myself with the slides, which I tend to do, to make sure we're moving that perception of our staff. So they're not putting up with something or enduring something that is not my expectation and that can actually impact their mental health in the long run and impact their ability to stay in this profession and continue to deliver great care, which is where we want to keep them. Healthcare workers are 5 times more likely to experience violence than any other profession. And since the pandemic, we have seen exponential increases in workplace violence. I mean, even in the physical abuse was always there. I mean, I've experienced it myself, typically more like in your ER, behavioral health, but it's moved into the inpatient, which of those inpatient nurses have historically never really experienced that level. And it's absolutely a pandemic in and of itself. Still, our emergency departments and our behavioral health units are the ones that are the highest risk. So we do try to focus a lot of our efforts of prevention into those areas. But it can also cost us, when we talk about going back to high costs, $18 billion annually for hospitals from workplace violence events. And so then you go into your burnout and your well-being. So we're talking about this nursing shortage. It's more about that retention and keeping. Since the pandemic, we've seen about 22% of nurses leave the profession. Wow. Not just leave acute care. At peak during COVID, that was about 35% that left the profession. Now, some of those have come back in, thankfully. But again, you think we're already in a shortage. And now we're losing nurses from the profession because of all of these things and how that compounds. And people are much better now about setting boundaries and taking care of themselves from a mental health perspective. And so if they're in a role where we can't protect them and support them, they're going to leave. And I don't blame them. The other piece from an acute care perspective too is you'll see nurses leave because there's so many more options now for nursing. They're outside of acute care that have better schedules, better hours, better benefits sometimes. And then you also are seeing a lot of nurses leave to go into mid-level practitioner roles. So again, that's all things that we're competing. So if we can make it better for them from a mental perspective, decrease burnout, that also impacts patient experience and patient safety. Again, if you move, next slide, I'll go into, these are just some things, again, I'm trying to go really quick. I'm sorry, we're over time. So when we talk about workload and stress, we are actively working to reduce overtime. So we have, or we are looking at some AI capabilities that we can marry with our scheduling system that can also pull in our census data, our staffing, and we can intentionally staff up on Wednesdays because the pattern and the predictive analytics say that's when our highest volume are. So we can staff intentionally to make sure we have enough staff here to keep our ratios where they need, make sure everybody's where they want, but then maybe we don't have as many on Fridays. So we staff down there, still having a buffer, right? To have that kind of, well, what if it's a little bit outside of the normal? But again, using AI to be much more intentional with where we're staffing, allowing more flexibility. So if we have staff that are willing to share a job and they want to do 2 8s because that works better for their life, their family, we can do job sharing. We have a lot of our PRN staff and we allow to do 4 6-hour shifts in those bigger, more high surge. So typically afternoon, we see a bigger surge in both admissions and discharges. So we've got a lot of traffic, testing's happening. So if we have a little bit of an upstaff there, but then we can downstaff where the patients aren't moving as much, they're sleeping. Again, still maintaining safety ratios, that type of thing. The other thing I'm really excited about and coming hopefully very soon, if not by the end, is an AI tool that will help chart for the nurse while they're actually doing the care. This is something similar that our physicians in the outpatient world have already started using. So if y'all have docs and they ask you, hey, I'm going to use this program called Dex, because they do get your permission. It is a ambient listening AI tool. We're going to start bringing that into the acute care for the nurses. And so while they come into your room, it's a little bit of a twofold. It's going to help them with charting, but they are going to need to narrate the care that they're doing. So here's the other benefit of that. A lot of times we as nurses, we know what we're doing. We're going to come in, we're just going to start doing something. We're not going to explain what we're doing because we know it. But for some people, if this is your first experience in acute care, you might be like, why are you touching me? What are you doing? I need you to tell me. They have to narrate now what they're doing so it charts for them. It's going to also benefit with that communication and explanation to the patient or visitors that are in that room, right? And so it's a benefit on both. So I'm super excited. And some of what's come from this is we have innovation departments within Novant. And so what we learned several years ago is sometimes people are great salesmen and they'll get in the door, but in reality, in application, it makes things more difficult for the nurse or the staff. And it's not as great as it sounded on the screen or in writing, right? And so we have innovation departments so that we can partner with different companies, try out different technologies, different staffing models, and see if it works kind of on a smaller scale before we make that a large scale. So I really appreciate that, and they'll trial things so that when we go to make it large scale, we know it's going to work. We already worked out the bugs, and it's really a benefit to the team and not as much of a, oh my gosh, here we go again. Is this going to actually be a good thing, or is it going to make more work for me? We now have virtual clinical resource nurses. So we have several nurses that are aging out, retiring, but how do we keep their knowledge to support our earlier nurses? Because we are seeing early career nurses leave the profession at a higher rate than your more experienced seasoned. And a lot of it is because we don't have the same experience at the bedside to augment their inexperience, again, compounding that anxiety. And so we have created virtual clinical resource nurses that are available 24/7. So for our older nurses who may not physically want or can do the job because it can be very physically demanding, but they still have such a wealth of knowledge. We have these nurses, they're actually in person on site at our tertiary facilities, so they're larger ones, but they have a connection virtually to all of our staff in our community facilities that literally at the ping of a button, they can be online and helping that nurse, whether it be a question about a procedure, a policy, an abnormal lab result. And we're also looking to expand that so there'd be a little bit more of AI oversight. This is how we then start to overlay, again, AI into this to augment nursing, where this AI can be looking at all things within our EHR, so our electronic healthcare record, and then they can pull things top of the list for these virtual resource nurses who can then be like, hey, Jane at Huntersville, notice this, it pinged this. Can you look at XYZ? Can you go in and ask the patient whatever that question might be. And again, augmenting for that newer nurse who may not pick up on some of the smaller changes that an experienced nurse would, but here's how we're augmenting it, pulling it to the level so that that VR nurse can see it and then communicate with that nurse back to the bedside as an augmentation. We're able to better catch things before it becomes a main event. Workplace violence. So again, I talked about the continuous education, so they're not thinking it's just part of the job, but we're also rolling out wearable personal panic alarms for all of our acute care Novant facilities. So if they're in a room, something happens, it's a push of a button, sounds an alarm, and people will come running to wherever they're at for assistance. We also have digital banners and physical stop signs. So we as a healthcare conglomerate are having to shift our perception as well. Traditionally, we're like, well, we don't want to stigmatize somebody. We don't want to put metal detectors. People will think it's not safe to come. Well, at this point, and with what we're seeing, with all due respect, I don't care what it looks like. We've got to keep our staff safe. We've also got to keep our visitors safe. And so these digital banners are put on our EHR if we have a patient who has historically been verbally or physically abusive to staff in the past. Highlighting to our team, there might be potential safety concerns. You might need to have a buddy when you go in that room. You might need to be aware of certain things. Or with the metal detectors, we need to make sure that you're coming in our walls, you're not bringing items that you can do harm with. And so again, making sure that we're balancing both the perception of the community. We are safe, we want to be safe, but here are some of the things we have to do to make sure we maintain that safety, both for our community and for our staff. And then if an event does occur, we have a plethora of resources that support that team member through whatever process they need to go through. So if something happens and they want to press charges, we are behind them 100%, both with legal support. I will pay them to go to court. I will ensure they have any follow-up mental health, physical help, whatever is paid, but we pay for all of that if something were to happen with that team member, and we make sure they know we're behind them. But we're also trying to do things ahead of time, so we're preventing any of that.
Allie, I think we were talking about additional penalties for any kind of abuse or violence on medical professionals. Has that gone anywhere?
So we are, again, sometimes it's a slow change. So that federal law has been in place where if it's a felony assault charge for any healthcare personnel. The challenge has been our local agencies and being willing to take the report, magistrates and judges being willing to, but we are seeing a shift. We are seeing where we are getting more support from our local PD and taking the reports and local support. We've got a lot of, our previous regional president did a lot of work at our local government area to kind of get that message out there and start it. So we are seeing the shift.
Seems like a very solvable problem.
It is. We still have.
It's interesting you say that. So what you'll see is, a nurse will get punched in the face and will press charges, but the patient has a psychiatric history or they're 72 years old or whatever, and the magistrate's like, well, they didn't really mean it, they didn't know, and so, the nurse still has a black eye, but.
And nurses by nature, I imagine, are empathetic.
Right. So it's tough.
Mike, you started this off with something I love. You said, our first priority is to take care of our team, whether it's your doctors, your nurses, your staff, and let them take care of the patients. What does Novant do really well with that? And anybody can really answer that, but
There's, so many things, and talking about burnout well-being.
Yeah, so I'll go into this. So historically, there was also a stigma for healthcare professionals if we had mental illness or we weren't managing. And so as hard as the pandemic was, it did bring to light the importance of mental well-being and the importance of those conversations. So you've had a significant shift in the last 6-7 years where it's okay to talk about your struggles from a mental health perspective. And organizations have put in place, so many tools. There's a list up here which is not even inclusive of everything that Novant has now offering, but a lot of that has happened over the last 6 years. And so we have Marvin, which is teletherapy option. We have found that healthcare individuals are much more apt to seek mental health care if it's on a telehealth, easy access process and a little more anonymous. because there is still some perception that there's a stigma there, which we are still working on moving past, but that's free of charge. That is a benefit to all of our team members. There's also free well-being apps that all of our team members have access to, so like NeuroFlow, that can help them from meditation, stress management, coping, but all again, free. And you know, this generation love the apps and the tech. And again, it's about access and what's easy for me and when I need to use it. We frequently, as an organization, do pulse checks that monitor our levels of burnout with our team. It breaks it down from nursing, physician, APPs, and so we can see which group might be struggling more. It also gives the ability for them to give comments of what they need. So a lot of times you might think you're supporting your team, but it's not really what they're needing or what support looks like for them. So this gives them a voice to tell us, if we're not meeting your needs, what does that look like and what do you need? We've also, we have an employee emergency assistance fund that is fully donor supported. And if somebody's having something outside of work that they need assistance from a financial perspective, they can apply for that up to $1,000 a year. It's a great program. Real-time support. So if we have a significant event in our building on a unit, we can bring in crisis support in real time to help support that team. And that's in partnership with that Marvin teletherapy, but that would actually be an in-person process. And then we have mental first help. So sometimes the people on your unit are the ones that recognize you're having a mental health crisis before anybody else. And so we do a lot of training for those who want to be a part of that, like emergency first aid kind of mental health. And they're on the unit, it's your leaders, it's your team members, that they can recognize it even maybe before you do and get support and help you.
That's great. Allie, I think everybody in the room and on Zoom as well can hear the passion in your voice for what you guys do. So it's fair. Hey, first of all, thank you guys for being here. I can't imagine a busy day in the life of a medical professional. I did promise Stacy one question last night as our board member of the year, but Dr. Gautam, I heard you sneaking something that caught my ear.
Sure.
Did you say Amazon is providing medical services?
Yeah, they are. Amazon has, I think, long tried to be into the healthcare space. They years ago formed a company with some other entity which didn't really pan out. Now they're going into more of urgent virtual care business where you could log in and try like an urgent care model.
I've reread 1984 multiple times. Here we are. Due for another one. So Stacy, do you have a question to wrap it up for these fine folks?
She took care of it.
Excellent. Bill, anything else from your end?
Yeah, Pat set up some outstanding Focus Fridays coming up. So the next one, we got Charlita Hatch, who is our new school district representative for District 1 from CMS. And then right behind that, you may be aware that Lake Norman Marine Commission has a new composure, new look. And so we're going to have a program on that in May, April 16th. Mark your calendar. We've got our education luncheon that will take place at Northstone Country Club, where we recognize the outstanding CMS, private school, and charter school teacher. We're trying to lock down Tricia Gautam as our speaker. She's on the education committee. Unfortunately, she doesn't quite know if she'll be pulled back into the legislature, so that's kind of a moving target. And then in June 19th, we have United States Senator Tom Tillis. He's going to come and give his swan song. So we're looking forward to that again in Northstone Country Club. So some great things. I already mentioned was our May 7th Women's Conference, I think. May 17th, the pickleball tournament. So a lot of great things coming up at the Chamber. And again, Novant is not only the speaker today and the Focus Friday presenting sponsor, but they're the presenting sponsor of our Leadership Lake Norman and our Junior Leadership Lake Norman programs. If we didn't have the support and partnership of Novant, we just simply could not do that. So thank you, Mike, and thank you for your team.
Thank you, everyone. Appreciate you all coming. Thank you. Thank you, guys. Do a little picture as well.